Good morning, Kentuckiana. I am Rebecca Walsh reporting live from Channel 14 News. Shoulder dystocia could be one of the scariest situations a mother in labor could face. Shoulder dystocia occurs during labor, sometimes without any indication or warning sign. Certain signs that do occur are the turtle sign, which is when the head is delivered and then retracted. According to the March of Dinas, shoulder dystocia occurs when the baby's head is delivered through the vagina, but the shoulders get stuck inside the mother's body. According to Dr. Henry Lerner, shoulder dystocia occurs in 0.5% of all deliveries. If approximately 4 million babies are born each year, roughly 20,000 will endure complications. Once the baby is stuck, the doctor has limited amount of time before the irreversible brain damage or death can occur. There are certain maternal risk factors that can increase the chance of shoulder dystocia developing during labor. According to the March of Dimes, the major risk factors include diabetes, carrying multiple babies, giving birth past your due date, newborn is predicted to be large, the mother is obese, being induced or receiving an epidural, previous shoulder dystocia deliveries, previous large babies greater than 4,000 grams, doctors using tools like a vacuum or forceps to help the newborn through the birth canal. According to the American Congress of Obstetricians and Gynecologists, also known as ACOG, there are labor-related risks with prolonged second stage and protracted active phase of labor. Complications of shoulder dystocia can lead to fatal hypoxia, causing brain damage or to a lifelong disability. According to Dr. Henry Lerner, the most common complication is a brachial plexus injury. This occurs when the nerves in the newborn's neck are essentially overstretched and can be permanently damaged, leading to either Erb palsy or Columbus palsy, depending on the location of the damage. The newborn could also break their clavicle. As for the mother, she could experience heavy bleeding and tearing of the uterus, vagina, cervix, or rectum. Now we can listen to Dr. Katz, a pediatrician from Louisville, Kentucky, explain shoulder dystocia.
It's okay. So it's David Katz, and I'm a pediatrician. I've been in practice here since 1981.
And why does shoulder dystocia happen?
Okay, so basically what happens is it's a mismatch where the baby is too big to be able to exit the birth canal easily, and the obstetricians will do things such as trying to literally have the nurse push on the fundus, the uterine wall through the abdomen, and then they may take a forceps and apply it to the baby's head to try and pull the baby out, and if all that doesn't allow the baby to come out, then sometimes it has to go further and actually pull with more force, and when that happens, sometimes the clavicle will break or crack and fracture. It doesn't happen very often because we usually have an idea of the baby's size and the mother's pelvis, so it's called cephalohead pelvic mother disproportion. That's what they measure the ratio, but sometimes, even though mathematically it should be able to work, the baby doesn't always come out anyhow, and that's where you get stuck. So we have like 350 newborns a year, and maybe we see this fracture happening where it's actually broken once or twice a year. And when that happens, usually what we do is we just pin the baby's arm to the shirt and keep it in a position like it would be in a sling so that there's no pressure on the clavicle, and the clavicle will put down new bone and mold. The other problem that can happen is something called Erb's palsy, E-R-B'(S), Erb's palsy. What happens is there are cervical roots nerves in the brainstem that come through your cervical, your vertebrae in your neck, the cervical vertebrae. Sometimes those nerves can be stretched, and the arm will actually be weak for a while. Generally, it improves and regains function. So 99% of the time, even when it happens, the baby is fine, and by the time they're 2 months old, you can't tell it ever happened. And then the treatment, we talked about what that is, and if there is a damage to the nerve itself, then sometimes we refer them to physical therapy as well.
Okay, well, thank you so much for your time.
Sure, no problem.
Thank you for listening to that. Thank you, Dr. Katz, for your information. According to the ACOG, if you're ever in this type of emergency, remember the line, be calm. B is for breathe, do not push. Elevate the legs into a McRoberts position. Call for help. A, apply suprapubic pressure, not fundal pressure. L is for enlarged the vaginal opening with an episiotomy, and M is for maneuvers. Now we can all watch a video about maneuvers.
Patient on a flat bed and in a low position. The flat bed will make the lumbosacral area more flat, and this will enlarge the area to facilitate the delivery more, and the low position to facilitate the delivery on your part. Other than that, you should empty the bladder, again to facilitate the delivery, and have a generous episiotomy. All of these have obvious benefits. Now after that, the assistants come, so the first thing to do is to do McRoberts maneuver. One assistant on each side. They will abduct and hyperflex the thighs of the mother on her abdomen. This will again further flatten the lower back and will further facilitate the delivery. And with this, while they are doing this, below, what you're doing is to do a lateral traction on the head in order to deliver it. Okay? So this is reporting, this by itself can deliver a very large proportion, about 90% or so, of all the shoulder dystocia. So you don't need the next step. But for the remaining 10%, this will not be sufficient. So we switch to another maneuver, and an assistant will be pushing through the lower abdomen in the suprapubic area. So if the baby is like this, of course you don't see this in normal patients. So the assistant will be pushing on the posterior aspect of the anterior shoulder. Anterior shoulder is the shoulder that is closer to the front of the mother's abdomen. So they will be pushing like this, okay? And you on the other side will be doing the traction again. Okay, so you do the traction with all of these maneuvers. Now this pressure can be constant or it can be in a rocking way. I can either do this constantly and the other one is doing the lateral traction, or I can do it in a rocking maneuver. Okay, that is intermittently, and I'm doing the traction. So we suppose that again this is not useful, so we switch to the next maneuver. And by the way, all of these maneuvers, so the McRoberts alone, the suprapubic pressure, and each of the next ones, each should not take more than 30 seconds. If it reaches 30 seconds and it's not useful, we switch to the next one. So the next one to switch to is called Rubens. You go through the vagina, and by 2 fingers, you push on the posterior aspect of the anterior shoulder. Kind of like the suprapubic, but you're doing it through the vagina, and again you'll do traction to deliver the baby. If this is not useful after 30 seconds, you keep this pressure and you add the other 2 fingers and push on the anterior aspect of the posterior shoulder and then try to deliver the baby. This is called Wood screw. Okay, Wood screw. If this is not useful, you reverse your hand, so you push on the anterior aspect of the anterior shoulder and the posterior aspect of the posterior shoulder, and you reverse the pressure and try to deliver. If this is not useful, so we switch to the next one. First, we will try to deliver the posterior arm, that is the arm that is close to the back of the mother, the posterior arm, okay? So we deliver this. Now, in order to deliver this one as well, we will rotate the baby in the direction of the face and the chest and abdomen. So we'll rotate the baby like this, okay? And then we'll deliver, this is of course outside, and then we'll deliver the other arm as well, and this may facilitate the delivery. Suppose that this is also not useful. In that case, we have to put the mother on all fours. That is on her hands and on her legs. Okay? And what we can do in that position, so let's assume that the mother is now on all fours. In this case, we can either exert traction, downward traction on this shoulder. This is the posterior shoulder because it's close to the back of the mother. So you can exert downward traction here and then take it out, or you can exert upward traction on the anterior shoulder and then also take it out. If even this is not useful, then you have to go to operation either in the form of episiotomy or in the form of cesarean section. Thank you.
Well, thank you very much for watching that video. It is important for the doctor to examine the mother and narrow down the chances for developing any risk. Doctors can determine the mother's pelvic dimensions and determine which type of pelvis the mother has. It is vital to know the mother's medical history and to always be prepared. Thank you for watching Channel 14 News. Rebecca Walsh, signing off.